right, to speak about something that is so very important to us in bone health clinics, which is heritable non-OI forms of osteoporosis. And we are so thrilled that she's staying up and talking to us today. So thank you and welcome back.
Thank you very much for this kind introduction. I'm really happy to be here. Actually, this is not my first slide here. Yes, greetings from Helsinki. It's 10 p.m. here, so it's nice to attend the meeting, and I'm really happy about this invitation, and I'm also happy to be able to present some interesting data from our own studies. So just about my background, I'm actually a pediatric endocrinologist working in Helsinki and also a little bit in Stockholm at Karolinska Institutet. And these are my disclosures. So I think osteoporosis as a diagnosis is very well known to all of you. But just to summarize the main clinical features, the patients present with fractures, especially spinal compression fractures, hip fractures, and wrist fractures. So these are the main fracture types. And then when we look at the bone tissue level, there is reduced bone mass and also abnormal bone microarchitecture. And then if we zoom in to the bone cells and molecular features, then this figure is actually just to remind you about the main bone cell types. So we have the bone resorbing osteoclast, the bone forming osteoblast, and then osteocytes, which are really important for normal bone homeostasis. They connect to each other and to osteoblast and osteoclast with these dendrites and form a tight network. And then we have all kinds of signaling pathways that are important for regulation of these, let me just get my pointer, regulating these different steps of bone cell maturation. And what's important is that osteoporosis is really a generalized bone disease, so it affects all parts of the skeleton. And of course, there are many different factors that can lead to osteoporosis. We have all the lifestyle factors, we have medications, different chronic illnesses that can lead to secondary osteoporosis, and then vitamin D, calcium intake, those are important for normal bone health. But it's been shown also in many studies that up to 85% of bone mass is actually determined by genetic factors. And there is an ongoing discussion whether it is multiple susceptibility genes that could lead to osteoporosis, or if there is just one major mutation in an important gene that leads to osteoporosis. And these latter ones are called monogenic osteoporosis, and these are the ones that I will be speaking today. So monogenic osteoporosis, or osteoporosis caused by a single gene variant in a gene that plays a major role in skeletal homeostasis. And if it's genetic, it is congenital, meaning that the defect is there from birth. But often these disorders present later in childhood or in young adulthood, or maybe only at late adult age. And in our own studies, we've, because of my pediatric background, we've focused on children, and especially these early onset forms of osteoporosis. But also, I think it's a good way of doing research, because then it's mostly these genetic factors that modify the phenotype, whereas in adults there is a long history of different types of lifestyle factors that have also impacted the skeletal phenotype. So optimally, for the research purposes, we get large pedigrees like this, but often we focus on single individuals with early onset osteoporosis. So these genetic disorders of the skeleton have been classified in this nosology, which was revised in 2023. Presently it includes more than 700 different genetic skeletal disorders already. But there is a separate group for osteogenesis imperfecta and some other forms of bone fragility disorders, and these include 55 different disorders to date. So even that group is expanding quite rapidly. But what's important for this talk is that actually there are only 6 non-syndromic forms of osteoporosis included in the nosology. So 6 different forms of monogenic osteoporosis, and actually 3 of these forms have been described by our group, meaning that there must be many other, but they have not been discovered. And I will be focusing on 3 different or 4 different forms of this monogenic osteoporosis. But there have been quite many studies already trying to see what is the prevalence of these monogenic forms of osteoporosis in different cohorts, and here you can see some of the numbers and proportions in different cohorts. And of course the prevalence varies quite a lot depending on the type of selection and the cohort characteristics. But in some studies they've shown up to 55% prevalence. But I think many of these studies actually have a problem that they include all the disease-causing variants, but also variants of unknown significance that could just be part of this polygenic nature of osteoporosis and not really the sole cause of early onset osteoporosis. So I think there is still room for additional epidemiological studies as well. So I will be speaking about 4 different types of monogenic osteoporosis marked here: LRP5, WNT1, SGMS2, and PLS3. I will go through some of the presenting features, natural course, characteristics on the bone tissue level, and then something about the therapeutic options and how we could maybe move towards precision medicine. But first, just one slide on osteogenesis imperfecta this time. But osteogenesis imperfecta is really, as you know, the most common monogenic form of skeletal fragility, and the patients have fractures, they might have deformities, often loose sclerae, and some other typical features. And in most of these, there is a defect in type 1 collagen, or somewhere along the pathway, and it's processing. But what I really wanted to emphasize here is that usually osteogenesis imperfecta is really regarded as brittle bone disease, meaning that there is hypermineralization of the bone tissue, and this has been regarded as the cardinal unifying feature in all different types of osteogenesis imperfecta. Whereas as I will show, in monogenic osteoporosis, the bone mineralization is reduced rather than increased. So I think that differentiates osteoporosis from osteogenesis imperfecta. So the first form of monogenic osteoporosis was actually reported by Matt Warman's group when they described this osteoporosis pseudoglioma syndrome, which is severe childhood onset osteoporosis with fractures and deformities, and they also have these ocular manifestations leading to early blindness. This disorder they were able to show was caused by biallelic mutations in LRP5, and this was actually the first study showing that Wnt signaling pathway is extremely important for normal bone homeostasis. And when there were biallelic loss of function mutations in LRP5, the signaling pathway didn't function normally, and this led to severe osteoporosis. But in this study, they also showed that even just mutation carriers had low bone mass, which was an important finding. When this paper came out in 2001, I was actually doing my postdoc in Toronto, and together with Etienne Socket, who ran the bone clinic, we hypothesized that maybe some of these patients with early onset osteoporosis or juvenile idiopathic osteoporosis could have an LRP5 variant. They didn't have the severe form, but they could present milder forms of osteoporosis. And so we screened 20 patients for LRP5 mutations, and we're surprised to find 3 of these patients to have actually LRP5 mutations, including this one frame shift variant heterozygous mutation in the index patient, and then the brother and the father was also found to have the same variant and osteoporosis. And also we could see that there were no mutations in COL1A1 and COL1A2, which I think was also an important finding, that there are other forms of juvenile or childhood onset fragility disorders that are not linked to type 1 collagen. And also that in many of these cases there were other affected family members, even if it was not typical OI. So when I then returned from Canada, we first focused on LRP5 and especially looking for these heterozygous mutations and the phenotypes in these patients. And we found quite many. We found 2 patients with biallelic mutations with this osteoporosis pseudoglioma syndrome, but many heterozygous individuals with different mutations in LRP5. And we could see that the young ones had normal bone mineral density and didn't have any fractures, but then the adults had quite low bone densities and very often had spinal compression fractures also, even if they had only the heterozygous LRP5 variant. So based on this, it looks like maybe it's not basically a defect in the bone mass accrual, but it could be accelerated bone loss in mutation carriers. But this, of course, would require a longitudinal study. We also saw that some of the patients had impaired glucose metabolism and hypercholesterolemia, but because of the size of the cohort, it was difficult to say definitely that it's caused by these variants. Then quite soon after that, I met this index patient here, a 44-year-old woman who had, after her pregnancies, developed multiple spinal compression fractures and had actually lost 7 centimeters of her height. She was then screened for Osteogenesis imperfecta, the COL1A1, COL1A2, and LRP5, but all these were negative. And we also noticed that there was a significant family history for osteoporosis. Her mother and mother's sister were similarly affected, and it looks really like an autosomal dominant condition. And here you can see radiographs of her mother and mother's sister who have exactly the same spinal osteoporosis. And so we did quite a lot of work, because at the time exome sequencing was not available, but we did linkage analysis, and then finally were able to identify a heterozygous mutation in Wnt1 in all these patients with osteoporosis, confirming that it's really an autosomal dominant form of osteoporosis. And then we also had this one family where 2 siblings had extremely severe, more like Osteogenesis imperfecta type 3 phenotype, and they had biallelic loss of function mutations in Wnt1. And this was, of course, an important discovery because this Wnt signaling pathway was known to play such an important role in bone metabolism, and LRP5, the receptor for the signaling pathway, was known to be important for osteoporosis pseudoglioma and primary osteoporosis. And then this study showed that Wnt1 is the major ligand for the signaling pathway. So as you probably all know, this signaling pathway is extremely interesting and important, and it's been shown that if there is increased activity of the signaling pathway, if there is an activating mutation in LRP5 or an inactivating mutation in this inhibitor of the signaling pathway, sclerostin, then this leads to high bone mass phenotypes. And then the opposite is, of course, is osteoporosis pseudoglioma syndrome, with severe osteoporosis with loss of function mutations. And our study added this Wnt1 mutations to this puzzle, so that the loss of function mutations in Wnt1 lead to severe osteoporosis. And we've then continued with this pedigree that we had in Finland, and we've been offering the family members genetic testing for this mutation, and we've identified many others with the mutation and osteoporosis. But interestingly, also 3 additional families who all have exactly the same missense variant in Wnt1. So it looks like this is an old founder mutation in our country, maybe coming from this couple early on, and it spread throughout the country. So there are probably additional family members. So as a pediatrician, I wanted to see if this is a childhood onset disease, and then we collected all the mutation positive children and adolescents up to the age of 30 years and went back to their fracture histories and did BMD measurements. And as you can see, some of these patients actually had quite a heavy load of peripheral fractures already at that time. They had low bone mineral densities. Nobody had spinal compression fractures. But 2 also had a bone biopsy performed, and we could see that there was clearly an osteoporotic phenotype. And interestingly, also these radiographs showed that the fibulae were really fragile looking, and also the tibia were quite thin, showing that it's a generalized bone phenotype already in childhood. What then is the natural course of the disease? In this family, we also performed spinal MRIs on 18 mutation positive and 14 mutation negative individuals from the same pedigrees. And we could see that actually the younger ones did not have any spinal compression fractures, but actually everybody who was aged above 50 years had spinal compression fractures. And in the older individuals, spinal osteoporosis was really quite severe. And you can see the spinal deformity index, which is like a sum of all these vertebral changes, that it's completely normal up to the age of 50 years. And then suddenly there is a rapid increase in spinal compression fractures. And we could see the same in this kyphosis Z-score. Many of them developed quite significant kyphosis then together with the spinal compression fractures. So that's Wnt1 osteoporosis. Then another type of monogenic osteoporosis that my group has reported in 2019 is related to SGMS2 gene. And here we started with this 3-generation Finnish family where the youngest one, this girl, I saw her in the clinic. She had 1 spinal compression fracture and a couple of peripheral fractures. And so in this family, we did exome sequencing on these affected individuals, and we could see that there is a heterozygous stop gain variant in SGMS2 gene, which is the gene for sphingomyelin synthase 2, which didn't have any known role in bone homeostasis at that time. And also I need to emphasize that some of these patients have these interesting calvarial donut-like lesions, these sclerotic lesions in the skull, which are quite variable. So then we identified another Finnish patient with exactly the same arginine 50 stop gain mutation in SGMS2. And then we also had two families from US who happened to have exactly the same stop gain variant in SGMS2. And it's been shown then in other studies that this is really a hotspot mutation for this type of osteoporosis. So these heterozygous arginine 50 stop gain mutations lead to autosomal dominant early onset osteoporosis and occasionally, or in many patients actually, to these sclerotic lesions in the skull. And you can see that the phenotype can be quite variable. Some had really multiple fractures, and in some cases the spinal osteoporosis is extremely severe from early age. So it varies despite the same variant. Then in this study we also had two families with the missense mutation in SGMS2, and these patients also had significant skeletal fragility, but they also had a skeletal dysplasia phenotype, spondylometaphyseal dysplasia, with quite significant spinal scoliosis, very short stature, and also short long bones and these metaphyseal changes. So quite a severe phenotype. Here you can see some of the skull lesions. Some patients don't have any lesions. Others have multiple and quite large and significant. And these patients with missense variants, they also had quite thick skull bone. So we can see that there is like a phenotypic spectrum with this type of osteoporosis. So we have the early onset osteoporosis phenotype with this heterozygous arginine 50 stop gain mutation, and then we have the severe spondylometaphyseal dysplasia caused by other types of mutations. And interestingly, these patients also have some variable neurological symptoms, especially recurrent facial nerve palsies that have been described not only in our patients but also in some of the other families. And now, more recently, we've identified a family where there is a lethal skeletal dysplasia caused by SGMS2 mutations and a different type of mutation. So it seems that there is really a complete spectrum of phenotypes related to this gene, depending on the location of the mutation. It's not quite understood how these variants lead to bone fragility. It's been shown in our collaborative study in Germany by Joost Holthuis, who studied the distribution of this sphingomyelin synthase intracellularly, and he's shown that whereas normally this SMS2, the protein encoded by SGMS2, resides on the plasma membrane, depending on the different type of mutation, it could be stuck in the ER or in the Golgi. And this disrupts the normal distribution of sphingomyelin in the cell. And this is basically the underlying cause, but how this then leads to bone fragility is not known, but this pathway is also important for providing phosphate to bone mineralization extracellularly. So this could be one way how these mutations lead to abnormal bone homeostasis. But it's been also hypothesized that could be the abnormal the ER and the cell membrane that could prevent the formation of these large cargoes that are needed for processing, for example, collagen trimers. Or there could be a defect in the cell membrane leading to inability to form these matrix vesicles that are needed for the calcification or mineralization process. So different hypotheses, but we don't really know yet at this point. But interestingly, then quite recently there was a publication reporting like an opposite phenotype, also linked to SGMS2. So we have the spectrum we saw in our studies, but they reported a family with high bone mass, a phenotype with a different type of SGMS2 mutation. So this is like the Wnt signaling pathway, actually, where we have the opposite phenotypes, and there was no functional study. It was just a mutation and the phenotype. So, of course, more studies need to be done to confirm this interesting finding. Then the next form, the fourth one, is PLS3 related osteoporosis. And I think this is extremely interesting because this PLS3 resides in X chromosome, and these mutations lead to X chromosomal inheritance pattern in families with osteoporosis. And this was first described by a Dutch group in 2013, and they reported these 5 families where especially the boys were affected by severe early onset osteoporosis and often or they always had these spinal compression fractures. So this PLS3 is a cytoskeletal protein and involved in actin bundling, and it was suggested that it could play a role in this osteocyte dendrite function and osteocyte network and lead to decreased mechanosensing in these patients. But there could be some other mechanisms, also insufficient mineralization by osteoclast and increased bone resorption by osteoclast. So more studies are needed here to really understand the pathogenesis. But this study was actually interesting. This is a summary of the reported loss of function variants in patients with osteoporosis. So mostly nonsense frameshift splice site or indels, some missense variants along the gene and in different domains of the protein. But in this study, this group showed that the PLS missense variants lead to X-linked congenital diaphragmatic hernia and body fall defects. They had this very large pedigree where this PLS3 missense variants segregated with a phenotype, and then other patients with different types of missense variants. So it could be that especially the loss of function variants in stop gain variants and frame shifts in PLS3 lead to osteoporosis phenotype, but not exclusively. So there have been some missense variants as well in patients with osteoporosis. And so here again, we wanted to see in our Finnish families what is the natural course of the disease and what are the presenting features. And we could also see that especially in boys, the spinal osteoporosis develops quite early on, and the older the males were, the more severe the spinal osteoporosis was. But then we also screened with MRI several females with heterozygous mutations in PLS3, and we could see that some of them actually had really extremely severe spinal osteoporosis. So it's not only a male type of osteoporosis, but affects females as well, but maybe a little bit later or quite a lot later in adulthood. So these WNT1, SGMS2, and PLS3 mutations, we've seen them in many Finnish families, but there are many other families that have been reported from other countries, and they've identified many different WNT1 mutations and several PLS3 mutations. But interestingly, there seems to be this hotspot mutation in SGMS2 leading to osteoporosis, and that has been reported in many large pedigrees with autosomal dominant osteoporosis. And these missense variants seem to be extremely rare. So what then happens on the bone tissue level in these different types of osteoporosis? And this is just to show how we can use these transiliac bone biopsies to get more understanding of the bone metabolism. We do those in pediatrics on clinical grounds when there is severe osteoporosis, but we've used them quite a lot in research to really see more precisely what's happening on the tissue level. So we get a nice piece of bone, and we can see the cortical bone, the trabecular bone quite nicely, and then we can get an estimate of the number and size and activity of the osteoclast and osteoblast, how much there is osteoid, this unmineralized matrix, and so really a lot of information. And if we go back to this early report on LRP5, there is some biopsy data already in that one. And as you can see, there seems to be increased osteoid here on the bone, on the surface of these green bone trabeculi, meaning that there seems to be some kind of mineralization problem. We've done quite a lot of biopsies in our WNT1 individuals, and this was in the original publication where we had 3 biopsies, and we could see that there is really very low bone volume, very inactive bone, low numbers of osteoblast and osteoclast, and low osteoid volume, so we don't see any osteoid here. The only patient where osteoid was present was this adolescent with a growth spurt going on. Here are some numeric values for additional biopsies. Here you can see that the osteoid surface is reduced, mineral apposition rate is reduced, bone formation rate is reduced, and the eroded surface, meaning the osteoclast activity, is also reduced. So it's very inactive. The same applies actually to PLS3 osteoporosis, where we've also done quite a lot of bone biopsies, and the situation is the same, that there is really very little osteoblast and osteoclast activity, and usually there is not increased osteoid on the bone biopsies, but in one biopsy we could see actually quite significant accumulation of osteoid on the surface of this trabeculae, and maybe here also. This was a patient with a complete deletion of PLS3, and we actually had in this paper 3 boys with a deletion of PLS3, and they all had severe spinal osteoporosis. And then from the biopsy, we studied also with backscattering electron imaging the mineralization of the bone tissue, and we could see that the mineralization was really reduced in both trabecular bone and cortical bone in PLS3 osteoporosis. And then SGMS2 osteoporosis seems to be very different on the bone tissue level, actually completely different. And the main feature in these biopsies that we've obtained so far is the completely disorganized bone tissue. Looks more like a woven bone. There is increased osteoid and really very abnormal bone tissue, and then also there seems to be increased impaired bone mineralization with this backscattering electron imaging compared with this normal curve here. So again here impaired mineralization as in these other forms. In SGMS2 osteoporosis, we've also then performed additional biopsies to study the osteocyte network. And here you can see how really nice the osteocyte network is normally in the cortical bone with these tightly connected osteocyte dendrites and a really orderly network. Whereas in SGMS2, these are patients with this arginine 50 stop gain mutation, this network is completely destroyed and so really abnormal osteocyte phenotype, which we haven't studied in these other forms of osteoporosis. So it remains unknown if that is a feature in these other forms as well. So if we summarize the bone tissue characteristics in these different forms of osteoporosis, I mentioned that in osteogenesis imperfecta, the mineralization is increased, as you can see here. But in all these other forms that we've studied, WNT1, PLS3, and SGMS2, these forms, they show decreased bone mineralization. So it's a unifying feature in all these three. There seems to be reduced bone turnover except for this SGMS2, where there seems to be a little bit more activity going on. And there seems not to be like an increased number of osteoclasts. So it's not increased bone turnover as in osteogenesis imperfecta we often see. So very different mechanisms leading to monogenic osteoporosis, Wnt pathway, these actin problems, and then sphingomyelin synthesis, very completely separate processes. But in these different types of osteoporosis, we can also see that there are some shared tissue level features like this impaired mineralization. So maybe when we treat these patients, we can focus on this because at the moment we don't have any targeted treatments for these forms. And maybe the defective osteocyte function could be part of all these. We've shown it in this SGMS2 type, but also in PLS3 there is some evidence for that. And WNT1 we've seen in some biomarkers of osteocyte function that they are abnormal, so suggesting that maybe there is an osteocyte defect as well. So some words about treatment in these forms of osteoporosis. This is actually a really interesting patient with PLS3 osteoporosis. She's interesting because it's a girl who has a heterozygous mutation in PLS3, and normally the girls are very mildly affected, but she actually developed severe early onset osteoporosis already early in childhood and with these multiple spinal compression fractures. And she has also a PLS3 missense variant and not a stop gain variant. But she has been treated with bisphosphonates and has responded really nicely. Here you can see the spinal radiographs after 4 years of bisphosphonates, and there is a almost complete reshaping of the vertebral bodies. And also the bone mineral density increases nicely. But early on, when we had done the biopsies, we're really hesitant to treat these patients with WNT1 or PLS3 osteoporosis with bisphosphonates because the bone turnover was reduced already to begin with, and we started the first patients with PLS3 osteoporosis with very low doses of pamidronate, but then everything went well, and now they are treated like any other osteogenesis imperfecta patient, and they seem to be responding very nicely to bisphosphonates. But in adults, you saw the spinal images of these adults with PLS3 osteoporosis and also WNT1 osteoporosis, and they've been treated with bisphosphonates, and you can see that still they develop these really progressive severe compression fractures. So clearly the bisphosphonates are not the ideal treatment for adults. We've also done a small pilot study with teriparatide in 3 patients with WNT1 and 3 with PLS3 mutation-related early onset osteoporosis. So these were, of course, all adults, and what we could see during these 2 years of treatment is that there was increase in bone markers. There was some mild increase in bone mineral density in 2 years, but it was only on average 5 to 8% in lumbar spine BMD. And for femoral neck and total hip, the response was quite variable. And it seems that these patients do not respond as well as other patients with osteoporosis do respond to teriparatide. And what we also saw in these patients, we treated 3 patients, and when we did bone biopsies at baseline and at 2 years, we could see that especially in these WNT1 patients, there was quite dramatically increased bone marrow adiposity after teriparatide treatment. So this is a little bit concerning. We could see the same also in PLS3 patients, but not as significant as in WNT1. So this means maybe that teriparatide might not be an optimal treatment either for these adults with WNT1 and PLS3 osteoporosis. And so when we are speaking about the Wnt signaling pathway, then of course sclerostin antibody would be maybe the ideal for precision medicine to really treat these patients. And there are a couple of reports already on using this romosozumab in WNT1 osteoporosis, and this is one reported case where the index patient after pregnancy had postpartum osteoporosis and was found to have WNT1 mutation. And here you can see the different therapies that she received, and also this romosozumab. And they reported a really nice response, plus 42% in lumbar spine and 16% in total hip, indicating that could be a really effective treatment. We have so far treated only 1 patient with this sclerostin antibody because the medication only recently became available in our country and only for women, postmenopausal women. But here we see 1 patient who with WNT1 osteoporosis from our large pedigree. So she already was diagnosed after pregnancy with morbus Scheuermann, maybe meaning that she had some spinal compression fractures early on. But then she was diagnosed with osteoporosis only at this point when she already had multiple vertebral compression fractures, which seemed to progress quite dramatically, and she lost more than 7 centimeters of her height quite rapidly. So she was first treated with estrogen, calcium, vitamin D, then denosumab, zoledronic acid, and then finally, now a year ago, she was put on romosozumab. There seems to be some response, but actually the lumbar spine BMD did not basically increase. There is some improvement in hip BMD during this year. So it's a little bit disappointing because we're hoping that these patients would really benefit from this type of therapy. But of course, this is a single case, and many more should be treated and analyzed really carefully. So to summarize what I've presented, I've talked mostly about these 3 forms of monogenic osteoporosis. Wnt1 signaling pathway plays an important role in many different steps in this osteoblast pathway. PLS3 has multiple functions in different ways. And then SGMS2, we have some theories how it could affect, but don't really have solid evidence for the mechanisms yet. So we can see that the mechanisms differ, the bone tissue features differ, but also the presenting features and the natural course of the diseases varies. There are, as I mentioned, there are some shared tissue level characteristics like this impaired mineralization that lead to bone fragility in all these forms. But this really separates them from the normal traditional osteogenesis imperfecta as we know it. And interestingly, it seems that there is an osteocyte network problem in these forms, which might be really important for when we search for new therapies, and maybe impaired coupling leading to disturbed bone remodeling. So to conclude, some monogenic forms of osteoporosis have been identified, but I'm sure there must be several others. And these are really, I think, valuable in a way that we learn more about the regulatory pathways in bone and the pathogenesis of osteoporosis. Maybe can identify some drug targets by studying these different forms. So gene-specific clinical features and disease mechanisms, and we've used bone biopsies that are really, really crucial in our research, but then of course in clinical practice it's not possible to take biopsies from all the patients. More research needs to be done, and really there would be a need for some kind of precision medicine in all these forms, but even for Wnt1 it's not there yet. And this is my last slide, and I'm really happy if you have any questions so we can discuss a little bit more.